We get our weekly groceries delivered through Instacart because once football season starts, game time is family time. I can get everything my family needs for the week, from reliable staples to specialty ingredients, all delivered right to my door in as fast as 1 hour. So I can stay on my game without missing a minute of the game. Visit instacart.com or download the app to get free delivery on your first 3 orders. Offer valid for a limited time. Minimum order $10. Additional terms apply. Instacart. Add life to cart.
With Lucky Land Slots, you can get lucky just about anywhere.
Dearly beloved, we are gathered here today to... Has anyone seen the bride and groom?
Sorry, we're here. We were getting lucky in the limo and we lost track of time.
No, Lucky Land Casino, with cash prizes that add up quicker than a guest registry.
In that case, I pronounce you lucky.
Play for free at LuckyLandSlots.com. Daily bonuses are waiting. No purchase necessary. Void where prohibited by law. 18+. Terms and conditions apply. See website for details.
Hey all, welcome back to the Real Life Pharmacology Podcast. I am your host, pharmacist Eric Christensen, and I thank you so much for listening today. Definitely go subscribe at reallifepharmacology.com. Get your free top 200 study guide on the top 200 drugs there. Great little resource if you're in pharmacology classes, if you're in clinical practice, just looking for a little refresher. Free 31-page PDF on the things that I see, as well as those things that are highly testable for all of you going through board exams and things like that. So with that, let's get in to the drug of the day today. We are talking about diphenhydramine, which the most commonly used brand name is Benadryl. This is a first-generation antihistamine. So long time ago, many years ago, the majority of people would use diphenhydramine for things like seasonal allergies. Now, we've since had the advent of second-generation antihistamines, and the big difference there was sedation. Diphenhydramine is very sedating compared to a drug like loratadine, for example, which is a second-generation antihistamine. So while diphenhydramine has fallen out of favor, and you don't see it used terribly often for like seasonal allergies and allergic rhinitis, I definitely still see this medication used a lot. And I would say the number one thing I see it used for is sleep and its sedative properties. It seems like a lot of the geriatric patients I work with use this stuff like candy to help them go to sleep. And there's a lot of reasons why that shouldn't be done, or we should do everything in our power to avoid using this medication for sleep. And I'll talk about some of those. But sleep, allergic rhinitis, I'll definitely see it for itching that's not controlled by other things, or it's from an unidentifiable cause. Basically symptomatic management of itching. Extrapyramidal symptoms from antipsychotics and things like that, or from Parkinson's disease. You will see some of the older anticholinergic type medications used for that, and I have seen diphenhydramine used there. Various allergic reactions, also potentially infusion-type reactions from certain medications. You may see diphenhydramine used in combination there, sometimes with like simple analgesics, like acetaminophen, for example. So lots of different uses that you might see diphenhydramine used for, and I just covered the ones that I see most often, at least in my practice here. So why did this medication fall out of favor? Well, I mentioned that sedative property, but this drug is also listed on the Beers criteria. So this is a medication that is not tolerated really well in elderly patients, and there's a lot of risks associated with it. So some of those risks, confusion, which obviously in a geriatric patient can be very problematic. And typically, most of these adverse effects are going to be dose related. So even if you have a patient that's like, no way am I absolutely going to stop taking, my diphenhydramine for sleep. I'm not going to stop it. there may be potential that you can say, hey, can we take 25 milligrams instead of 50 milligrams? Can we just take it as needed or every other night or whatever the case may be? There's plenty of different options there. But even just reducing that anticholinergic burden, I think, is really, really important, even if we can't get a patient off the medication altogether there. So confusion, I mentioned, fall risk associated potentially with that sedation, dry eyes, dry mouth, urinary retention, constipation, lots of troublesome adverse effects that can be caused by anticholinergics, in particular older first-generation antihistamines like diphenhydramine. Now, interestingly, there is reported in the literature a potential paradoxical effect. So basically, the opposite of sedation can happen in pediatric patients. I would say it's not something that I've seen incredibly often in talking with parents and that type of thing. But I think it is important to understand that if a patient reports, a kid's sick or whatever, that type of thing, and I give them some Benadryl, and they didn't go to sleep at all, and they seem like they are even more wound up. I mean, that's a situation where maybe that diphenhydramine caused some of those symptoms. So again, something to look out for, and maybe something to alert parents to if they are giving their kids Benadryl or diphenhydramine. But there again, if they're trying to give their kids diphenhydramine or Benadryl, I'm definitely going to be asking a lot more questions as to why and what are you using for and all that sort of stuff. So, but anyway, just something to be aware of there. All right, so I think that's going to wrap up the first section here. I'm going to talk about drug interactions and the prescribing cascade at length, because I've got numerous examples that I want to share with you right after the break here from our sponsor. If you're in the market for Pharmacist Board certification study materials, our review materials are reviewed annually and updated, so definitely go check those out. If you're listening to this right now, we are ready to go for 2021 and into the spring and fall. If you're listening to this 2-3 years down the road, just know that we do update that content on an annual basis, usually late in the year. So go check that out. Pharmacotherapy exam, geriatric exam, ambulatory care, MTM certification exam, NAPLEX content. Definitely go check out all those resources if you're taking one of those exams. In addition to that, we've got books that make great gifts for students and other healthcare professionals, just describing clinical thought process, case studies, clinical scenarios. Again, all those links are at meded101.com/store, STORE. Go check those out, support the sponsor, and help support this podcast and keep it free for all to enjoy. All right, so finishing up on drug interactions. First, I wanted to talk about the prescribing cascade. So some of these are maybe not necessarily true drug interactions, but I want to demonstrate to you some of the things that I've seen as a practicing clinician. So, for instance, if you see a patient with a new diagnosis of dementia, and we are adding medications for dementia, like memantine or donepezil, for example, you've got to look at that medication list, okay? Because anticholinergics are notorious. So anticholinergics like diphenhydramine are notorious for causing confusion. I've seen it so many times where a patient, maybe starts, 50 milligram dose of diphenhydramine, a higher dose for a geriatric patient, and it increases their confusion, and family members and everybody else is wondering, maybe it's, dementia and their symptoms are worsening now or whatever the case may be. But it could be from that anticholinergic effect. So think about that. When you see memory medications added, make sure it's not a drug-induced cause of confusion or memory impairment. Sedation, again, another one. If you see stimulant-type medications being added, you've got to look at that medication list and make sure that we're not adding on sedative type medications, or we're not experiencing adverse effects from sedative type meds like anticholinergics. Or the situation I've run into so often is patients basically taking over-the-counter diphenhydramine or other sleep aids, and they don't tell a healthcare professional. They just say that they're tired all the time. Okay, so you got to do that investigative work and figure out if over-the-counters or other things are tripping them up. Other meds to look out for, so eye drops, particularly like artificial tears or Restasis for dry eyes. Look at that medication list. Anticholinergics can cause bad dry eyes. Dry mouth, same thing. So if you see a saliva substitute, for example, go back and look, see if they're on any anticholinergics. If you see, starting of tamsulosin or increasing in dose. So again, tamsulosin is used in BPH to help with urine outflow. Anticholinergics can worsen that symptom. And then, of course, constipation. If you see a lot of laxatives on board for a patient, make sure they're not on a high number of anticholinergic medications that are worsening that constipation. So while not necessarily true drug interactions, there's a relationship there. The prescribing cascade, if you will, where you start an anticholinergic and then all of a sudden you're managing side effects from that anticholinergic like diphenhydramine with other medications. All right, so other things to think about in relation to drug interactions and diphenhydramine. Really the two big things are a CNS depressant effect, so adding other sedative medications. So that's really common sense. Your Z drugs like Zolpidem, benzodiazepines like your Ativans and Klonopins, opioids, alcohol use, all those can really pile on and have additive, sedative, CNS depressant type effects. And then anticholinergic burden is the other one I think of as well. So thinking about some of those anticholinergic adverse effects, looking at that medication list and saying, hey, which one of these meds, ones of these meds have anticholinergic effects, super, super important. So some antipsychotics are more anticholinergics than others. Tricyclic antidepressants, some older skeletal muscle relaxants, overactive bladder drugs, even inhaled agents for COPD could, especially add to things like dry mouth, potentially urinary retention. I have seen that. Again, it's not incredibly as common with the inhaled agents because we don't get as much systemic absorption typically, but it certainly can be associated there. And then IBS, irritable bowel syndrome agents like dicyclamine, for example, has strong anticholinergic effects and could definitely add on to those effects from the diphenhydramine. So I hope that gives you some good clinical practice pearls and some background on diphenhydramine. If you enjoyed the podcast today, leave us a rating, review, share us with a friend, colleague, or go support the sponsor. Snag your free Audible book at meded101.com/store. If you've never tried that before, definitely go snag one for free. I've got a couple different books that are 6, 8, 10 hours in length that you can listen on your commutes to work or wherever you're driving or exercising, whatever the case may be there. And of course, if you want to reach out to me, mededucation101@gmail.com is my personal email. If you got any suggestions, comments, definitely feel free to reach out to me there. You can also find me on LinkedIn as well, Eric Christensen, PharmD, BCGP, BCPS. So I thank you for taking the time to listen. Take care. Hope you have a great rest of your day.
Judy was boring.
Hello.
Then Judy discovered ChumbaCasino.com.
It's my little escape.
Now Judy's the life of the party.
Oh, baby, mama's bringing home the bacon.
Whoa, take it easy, Judy. The Chumba life is for everybody. So go to ChumbaCasino.com and play over 100 casino-style games. Join today and play for free for your chance to redeem some serious prizes. ChumbaCasino.com. No purchase necessary. Void where prohibited by law. 18+ terms and conditions apply. See website for details.